Dear Chair, dear audience, let me introduce you my one-year progress on the PhD topic of New Frontiers in the Diagnosis and Management of Cutaneous Malignancies. I am Lili, Gulyás, a medical doctor and a full-time PhD student at the Department of Dermatology at Semmelweis University. I'm happy to share you my vision, which is improving the diagnosis and management of cutaneous malignancies, and therefore my mission is to identify the most effective serum biomarkers and treatment options in these diseases. Here you can see my two ongoing projects, and let me introduce you my first one, which is investigating the predictive value of different biomarkers for post-diagnostic events in cutaneous malignant melanoma with the methodology of a systemic review and a meta-analysis. Cutaneous melanoma is the fifth most common malignancy in the US, and we can say that depending on the primary tumor stage, the 5-year survival can vary between 98 to 22%, and every one out of all of three melanoma patients will have a disease recurrence. Unfortunately, in the clinical practice, there are no relevant biomarkers with relevant predictive values are available. Of course, we use some biomarkers in the clinical practice like LDH and S100, however, they have low predictive value. In the past few decades, there are some promising biomarkers appeared which could help monitoring the patients and the therapy. Therefore, our aim is to compare the predictive value of different serum biomarkers in malignant melanoma to predict disease progression and patient survival. So our clinical question is, which biomarkers have the highest predictive value of patient survival in melanoma patients? We use the PEO framework, where our patients are melanoma patients, and we'd like to compare different serum biomarkers in the outcome of death, disease progression, and patient survival. Our hypothesis is that novel serum biomarkers have higher predictive value for the prediction of survival in patients with melanoma. Here you can see my final search key with the date of the search in 3 main databases and the flowchart of the selection. In the end of this process, we have 200 eligible full texts. Here you can see hazard ratios of overall survival association with different serum biomarker levels. Hazard ratios are unitless numbers which express the probability of an event happening, in this case, the patient survival. So for example, in the case of LDH, the 1.72 hazard ratio means that patients with the elevated levels of this marker had 1.72 times less chance to survive than those patients with the lower levels of this marker. If we look at our results in different therapeutic groups, we can see that the LDH didn't correlate significantly in the BRAF/MEK inhibitor-treated patients. However, it correlated significantly with the overall survival of the patients in the immune checkpoint inhibitor-treated patients with a hazard ratio of 1.97. In the case of circulating tumor DNA levels, the detectable levels of circulating tumor DNA correlated significantly with the shortened overall survival of the patients, with the hazard ratio of 3.52 in the immune checkpoint inhibitor-treated patients and 1.99 in the BRAF/MEK inhibitor-treated patients. Here in this slide, you can see hazard ratios of progression-free survival association with different serum biomarker levels. Again, if we look at the biomarkers in different therapeutic groups, we can see that in the case of LDH, it didn't correlate significantly in either group. However, the circulating tumor DNA levels correlated significantly with the progression-free survival and the circulating tumor DNA levels in the immune checkpoint inhibitor-treated patients and in the BRAF/MEK inhibitor-treated patients with a hazard ratio of 2.23 and 2.17. I'd like to highlight another interesting finding about neutrophil to lymphocyte ratio, which can be calculated easily from root blood parameters. We have hazard ratios of overall survival and progression-free survival of neutrophil to lymphocyte ratio. And we can see that in the immune checkpoint inhibitor-treated patients, we have poolable results with a hazard ratio of 2.38 and 2.54, which means that patients with higher levels of neutrophil to lymphocyte ratio had less chance to survive and progressed in a shorter time. Our study has some strengths and limitations. It's a very comprehensive analysis with objective measurements, and it could help monitoring the therapy and predict the patient survival. However, the limitations are that there were different cutoff values in some of the biomarkers. The study types were different, and the population is a bit heterogeneous too. So our conclusions are that predictive power of different biomarkers vary among therapeutic subgroups. Circulating tumor DNA levels correlate significantly with both the overall survival and progression-free survival of the patients in all therapeutic groups. LDH correlates significantly only with overall survival in the immune checkpoint inhibitor-treated patients, and neutrophil to lymphocyte ratio correlates significantly with overall survival and also the progression-free survival in the immune checkpoint inhibitor-treated patients. And the implication for practice would be that when available, of course, circulating tumor DNA level measurement is recommended in the future. The usage of LDH as a general tumor marker is still advised, especially in the immune checkpoint inhibitor-treated patients, and calculation of the neutrophil to lymphocyte ratio in the immune checkpoint inhibitor-treated patients could be helpful to monitor the therapy and the therapeutic response. The implication for practice, for research, is that which biomarkers are worth further investigations. Unified cutoff values are needed, and that the neutrophil to lymphocyte ratio should be investigated in other therapeutic settings too. Here you can see the progress of my first project, and let me briefly introduce you to my second one, which is investigating the safety and efficacy of systemic therapies in locally advanced or metastatic basal cell carcinoma with the methodology of a systemic review and the meta-analysis. Basal cell carcinoma is the most common malignancy among Caucasian populations. It can be treated successfully through various procedures. However, there are some cases when the lesions have progressed to a point where these traditional treatment options are no longer feasible. In these cases, these lesions can cause disfigurement, also intracranial penetrations, affecting not only the physical appearance of the patients, but also their quality of life and potentially even life expectancy. For these advanced cases, there are some systemic treatment options are available, like sonic hedgehog inhibitors and PD-1 inhibitors. Therefore, our aim is to assess the therapeutic efficacy and safety of systemic therapies in this patient population. So our clinical question is, are PD-1 inhibitors effective for patients who fail to respond to sonic hedgehog inhibitor therapy? We use the PICO framework, where our patient population are locally advanced and metastatic basal cell carcinoma patients, and we'd like to compare PD-1 inhibitors to sonic hedgehog inhibitors in the outcome of efficacy and safety. And our hypothesis is that in locally advanced and metastatic basal cell carcinoma patients, PD-1 inhibitors are an effective and safe therapeutic options after treatment failure to sonic hedgehog inhibitors. And the clinical and research implication is to find the most effective and safe systemic therapy for these patients after failing the first-line systemic treatment. Here you can see a preliminary research key, which I'm currently working on. And to summarize, I have two ongoing projects, both of them in the field of dermato-oncology. And I'd like to wish you a good afternoon with a quote from the great movie Star Wars, that do or do not, and there is no try. Thank you very much for your attention.
Thank you for your presentation. I was wondering, what is your current practice in your clinic regarding your first topic? Can you measure the circulating tumor DNA, and how do your results change your current practice?
So currently in the clinical practice, as for my knowledge, there is not in the clinical practice to measure circulating tumor DNAs, because in the articles, usually they did it retrospectively from frozen samples, for example, frozen plasma samples, and measured that way. So it's not in the clinical practice because you need a PCR for that, and you have to buy a kit for that, so it's a bit pricey too. So it's not in the clinical practice yet.
But it will be someday, what do you think? Because this is what it's all about.
Yeah. So I think it should be, because it's more specific too, because it can target specific mutations too. So in the future, I hope so it will be one day. Yeah, it would be great.
Thank you.
Do you think you can conclude that circulating DNA is better than LDH?
Of course, it's an indirect conclusion because so these were pooled results of hazard ratios, and we can't really conclude a direct, we can't compare them directly. So it's an indirect comparison.
But even indirectly, is it better or?
In some ways, I think yes, but it's hard to tell because hazard ratios are just, it says that a patient has a chance to survive or to progress.
You also mentioned, I think, that LDH was not predictive in PFS, in progression-free survival.
Yes.
But didn't it approach significance?
No.
Maybe I missed it then. Where is it? Sorry.
In the immune checkpoint inhibitor and BRAF inhibitor treated, it crosses the no effect line.
I mean, that was not too far from significant.
Not far, but yeah, it's not far from significant.
The only reason why I highlight this point is that when it comes to biomarkers in melanoma, I think in the field, when they check human intrinsic markers, I think they still establish that LDH is one of the best ones. And I don't think that your results disagree with it. So I would be just cautious saying that it's not good. I would say that under the circumstances where you studied it, with the heterogeneity, it did not yield to be significant as much as it did for circulating DNA, but it still may be a really good predictor. Okay. And the other question I have is, like, you have a lot of studies actually. Could you do a stratification by melanoma subtype, like a stage at least? Because immune checkpoint inhibitor treated patients could be also like adjuvant and could be also like advanced. It's not clear to me what you use here. Yeah,
in the majority of the cases, they are in an advanced stage, and there were only one or two studies with lower stages. So the majority of the cases, they don't get on the lower stages of the drug.
Maybe it's worthwhile to check those studies that looked at the early stage, because in those studies you may actually see that circulating DNA is really superior, because this may be more sensitive in that setting, whereas in the later stages they may be kind of similar.
Okay.
Thank you.
Thank you for coming.
Congratulations for your presentation. When did they measure the levels of biomarkers? So before the therapy, or also used it for follow-up?
Thank you for your question. These are baseline levels. There were some articles when they measured by the follow-up, for example, after 6 weeks, after 12 weeks, and we are thinking about pulling them together if we can, and doing an analysis on them, but much fewer studies, so maybe 10 or something like that, measure that.